Welcome everyone. In today's video, we are going to talk about spinal shock. Spinal shock is a transient physiological state following spinal cord injury, most often a complete transaction of the spinal cord, which is characterized by the triad of paralysis, hypotonia, and areflexia. So basically, this is a state of flaccid paralysis, which is followed by gradual return of the reflexes and hyperreflexia. So, in spinal shock, we have a period of flaccid paralysis followed by return of reflexes, hyperreflexia, and spasticity. So, let us have a look at the phases of spinal shock. There are four phases. The first is areflexic or hyporeflexic phase. Now, when we talk about spinal shock, we are generally referring to this phase of spinal shock. The next phase is initial reflex return, followed by initial hyperreflexia, followed by final hyperreflexia or spasticity. So we can see that in spinal shock, we have a areflexic phase or a phase of flaccid paralysis to spasticity. Now let us have a look at the phases individually. The first phase is areflexic or hyporeflexic phase, which develops immediately after the spinal cord injury and lasts up to 24 to 48 hours following the spinal cord injury, and it is characterized by loss of reflexes below the level of spinal cord injury. The cause of this is the loss of basal excitatory stimulation from the brain to the neurons involved in the reflex arc. So, brain has a basal excitatory stimulation of the neurons involved in the reflex arc. The spinal cord injury disrupts this basal excitatory stimulation, leading to less responsiveness to stimuli and loss of reflexes below the spinal cord injury. This is followed by the phase 2, which stays for the next 24 to 48 hours. So 0 to 1 days or 0 to 2 days is the first phase. Then for the next 1 or 2 days is the phase 2 or the initial reflex return. In this phase, some of the reflexes return below the level of the spinal cord injury, and polysynaptic reflexes return before monosynaptic reflexes. Now the first reflex to return is the Bulbocavernosus reflex, which is very important. The most important part of this topic is the Bulbocavernosus reflex and its interpretation. So let's see the Bulbocavernosus reflex. So what is this Bulbocavernosus reflex? It is the contraction of the anal sphincter in response to squeezing the glans penis or the clitoris. So to test this, the examiner puts one finger in the anal sphincter and with the other hand he squeezes the clitoris or the glans penis. An alternate method is to tug on the indwelling catheter if the patient is catheterized. Now if there is a contraction of the anal sphincter, the Bulbocavernosus reflex is present. Now we have seen this is the first reflex to come after a spinal shock. So this signifies end of the spinal shock or the first phase of the spinal shock. Now this is very important because after the Bulbocavernosus reflex has returned, whatever neurological injury is present is attributed to the spinal cord injury itself and not to the spinal shock. So if there is a complete loss of motor and sensory power or response following return of Bulbocavernosus reflex, then it is a complete spinal cord injury. However, if some motor or sensory response is present after the return of this reflex, it is an incomplete spinal cord injury. And in a complete spinal cord injury, the chances of neurological recovery or improvement are almost negligible. Now, one thing we have to remember is that injuries to the conus or cauda equina may permanently disrupt this reflex, making this interpretation difficult. So, even after the spinal shock has subsided, if there is an injury to the conus or cauda, this reflex may not come back. The third phase is the phase of initial hyperreflexia. It is for the next 1 to 4 weeks, and the reflexes start to increase, and this is due to increased expression of neurotransmitter receptors. So the neurotransmitter receptors increase, and this leads to increase in the reflexes. And the final stage is the final hyperreflexia or spasticity, which develops over next 1 to 12 months, which is characterized by hyperreflexia with hypertonia, which is due to the loss of inhibitory input of the motor neuron or the upper motor neuron below the level of spinal cord injury, like in a normal upper motor neuron lesion. Now, one thing is very important, that sometimes people confuse this spinal shock with neurogenic shock. Now, these are completely different entities. So, what is neurogenic shock? Neurogenic shock is due to disruption of sympathetic nervous system pathways in high spinal cord injuries of T6 or higher. So, in these injuries, the sympathetic pathways may be disrupted, leading to a loss of vascular tone. So, this loss of vascular tone leads to hypotension and a bradycardia. Normally, with hypotension, in a hypovolemic shock, we have tachycardia, but in neurogenic shock, we have bradycardia. And the third feature is vasodilation or a warm flush skin due to this loss of vascular tone, and the treatment is vasopressor. So, in a spinal shock, the problem is neurological, whereas in a neurogenic shock, it is a hemodynamic problem. So, hope the difference between these two is clear. So friends, in this video we discussed spinal shock and its phases. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you would like to be covered in the future videos. Thank you.